pearls for the management of a Morgagnian cataract. This is being done under topical anesthesia after staining the anterior capsule and after inserting viscoelastic. Main port and side port is being made. .26-gauge needle was used to make a nick in the anterior capsule. The milky fluid is coming out, which is being taken out with the help of viscoelastics. You can see how much time taking it is. Now again we are trying to make a small circle in the center. It's quite tough because the anterior rhexis flap has got no support. Again you can see milky fluid is coming out, viscoelastic is being injected. Now at the end this circle is being completed. Repeated injection of viscoelastics has led to removal of lot of milky fluid and almost there is no support for the flap, which is making it tougher and tougher. Finally, a small circle has been made. Now we are just trying to take out the milky fluid very gently so as to have an idea what is lying beneath. Now a venous scissor is being used to make a cut in this circle, and with the help of rhexis forceps a bigger rhexis is being made. You can see after every 2-3 clock hours I am trying to hold the leading edge of the anterior capsular flap. We should not hesitate to put in injection of viscoelastic in between. Now a bigger complete CCC has been achieved. The downside of this whole procedure is that there is no support for nucleotomy procedure. You can see almost only the central hard nucleus part is left out, and doing any sort of nucleotomy and chopping is very tough. So the whole procedure is being done very gently and in a very controlled manner. The burst phaco mode has been put on. You can see the red glow from behind, and this was a supracapsular flip. It's safer because the nucleus has almost come out above the plane of anterior capsule, and so any sort of maneuver is actually not putting any stress either on the posterior capsule or the zonules. It's a well-known fact that zonules are very weak in these cases. So each and every step is being done very gently. Chopping the larger fragments into smaller fragment will lead to lesser consumption of phaco energy. That is the principle behind this procedure. I don't hesitate to change the chopper with the blunt instruments at the end of surgery so as not to damage any structure, because there is no support behind. Now for taking out very small but harder fragments, no need to put phaco probe again and again. This can be taken out by slow sustained injection of viscoelastic and by pressing the posterior lip of the main wound. While putting IOL, we have to keep in mind that jonules in this case are weak, so inserting the IOL has to be a very slow movement. Using the second instrument in the other hand actually blocks the flipping of IOL, which I encountered many of my cases. The haptic has been put into the bag with the help of viscoelastic and the second instrument.